All right, you guys ready?
Sure.
All right, who would like to start us out this week?
I can go
I can.
anytime.
All right. Um, I think you already have control, Howard, because I can't give it to you. I think you just have to hit the play button to share your screen.
See it now?
Yep, there we go.
Good. All right. Here's an interesting patient that was imaged for acute aortic syndrome. So here on the pre-contrast series, I know it's a bit noisy, but if I narrow the window width to improve the contrast, one can see that there is substantial high attenuation abnormality in relation to the ascending aorta at a minimum, going into the aortic arch as well, distal aortic arch as well. Then it becomes difficult to see beyond that because, in part, because of some streak artifacts and so on, but definitely abnormal. So here is the contrast portion. And you will see, let me just see what this jumping.
Howard, try to go to full screen. Try to double click and just go to full screen because it's jumping again. See if that helps.
Okay. All right. So here we see that we have clearly a communicating aortic dissection that starts about there. I'll show you some more, and involves the descending aorta. And then there is substantial intramural hematoma in the aortic arch and the ascending aorta. So let me make a coronal out of this, and I hope it doesn't jump too much. Go to full screen. And we can see that there is a communication between the true and false lumens in two places. Here is a relatively large one, but if we go and look some more, we can see that there is an additional tear and communication right here in distal aortic arch, right there. So this, and I must admit, I don't know what this very discrete area of low attenuation is in relation to the false lumen there. But certainly this is consistent with a type B dissection with the tears in the distal aortic arch and descending aorta, with retrograde extension to involve aortic arch and ascending aorta, and a substantial one at that. So kind of this scenario where one sees at least an intimal tear here, and then retrograde extension of hematoma. So this is the entity right there. And I will just show you that this is the case where it's not necessarily the case that you need to operate on these patients. There are situations in which you can just treat the descending aorta and try to occlude the tear. So here, for example, in this article, there's a discussion about that. And this is what they did in this patient. So I will show you that they went in and put in a stent graft, and you'll see the placement of it there.
Yeah, Howard, go to full screen again. That seemed to fix the problem, and when it's not, then it jumps. Yeah.
Okay, I'll try to stay in full screen. You can see that there is opacification on the angio, this being in the operating room, of the true and false lumens. And then I will show you that after placing the stent and doing the angio, there is still, it surprised me a little bit because I thought they would have covered that, but there is still a leak or communication to the false lumen up there. So that meant that they had to extend and put an additional graft further in. So this is the angio series after placement of the additional stent graft more proximally, and I know it covers the subclavian, but now they've taken care of that stent. So kind of an interesting case of type B with retrograde extension and treatment of it in this instance with endovascular stents to cover the tears that we saw.
So Howard, the articles called it a type A dissection. So was it called type A in the article that you showed because does having the ascending aorta?
Yeah, so let me show you the picture where they, as you see here, they are the different ones. So we can have a type B, we have a retrograde type A right here, which is what we have in this instance. And then this is the more conventional intimal tear in the ascending aorta. And you see those differences there. So that's the way they've described this one, the situation.
So basically anything that involves ascending aorta gets A, even if the tear was distal and it went retrograde to involve A, it's still a type A. That's...
Yeah, in terms of the traditional description.
Right.
But the management implications are different if you think that this is the pathology. You don't necessarily have to go in and operate on these patients to take care of the ascending aorta, to take care of this tear right there.
Got it.
Yeah.
Yeah, and Seth wrote an article in Radiology with his Maryland group on clarifying type A versus type B, you know, just with the involvement. But yeah, this is a nice distinction with the retrograde involvement because it's secondarily affecting the ascending aorta.
Yep. Yep. Okay, I hope it doesn't jump too much. So let me show you this one. I will go full screen here. This is the kind of situation that I encountered. Can you see okay? Not jumping too much now?
It's working great.
Okay. Where sometimes residents ask me, this is a CTPA. We didn't really opacify now it's not this particular case, but this is the kind of case that the pulmonary artery wasn't opacified very well. Do you think we should repeat it? So here, if we actually measure, and some people are pretty rigid about 200. This one is 155, as you can see there in that range, and use that number. And we've talked about this before, and I really discourage that because you can certainly diagnose PEs at less than 200, and I think it's fine. And here's a nice example of where indeed down here you can see that one can confidently diagnose this PE. So you see it there, and you can see, and I need to show you maybe a better one, like a coronal of that. But it's easy to diagnose that kind of embolus with confidence.
Yeah, where does the 200 threshold come from? Because I've heard that, I've heard 150, which I still think is higher than it needs to be.
It's,
I can't find any actual data on it.
no, it's all
complete garbage. Complete garbage. I'm sorry, it drives me crazy. People like put ROI.
Yeah, exactly.
well, we're in all in agreement.
Scream. Like I come in and I see a study where it's on the P. I'm like, what? It's like if you can see it, you can see it. If you can't, you can't. Right?
Yeah.
Attenuation. It's all about the noise relationship between the noise and attenuation. If you have, it drives me nuts. But yes, you know. But I don't know. People are like, oh, it's less than 200. You can't. It's non-diagnostic. I'm like,
Yeah, that's nonsense.
It's just. I'm sorry, Jeff. I interrupted you. It's just that is like one thing that just strikes a nerve with me.
Yeah, I was agreeing with the same thing, and there really is no basis. And if I remember it, you only need about a 20 Hounsfield unit difference between the clot and the blood pool to see it. So I discourage that too. Yeah. And you know, sometimes you have a good 300 or 400 in the central pulmonary arteries, but you have nothing out in the periphery. It's more important to look at the homogeneity than some arbitrary cutoff. And I think, Travis, you mentioned one time, suppose it's 199. Is it non-diagnostic?
Yeah,
well, exactly. Yeah, and I have examples where as low as 115 in the pulmonary artery, and you can still see pulmonary emboli. And you know, but I think you could probably even go a little bit lower in the acute setting, at least. And but as Seth said, it depends on the quality of the study too.
Right.
And the size of the patient. I had people with, Hounsfield units of 300 who are morbidly obese, and they're scanned at 100 kV, and the noise, standard deviation is 90, and you can't see anything beyond the central PAs, even though technically it's a quote unquote, good bolus. But it's followed by some people here, and I yell and scream at them all the time. Like, if I'm reading it, just remove the ROI so I never see it, just please. But
yeah. This is not a mystery case, but it's instructive. It's kind of interesting. So this is an unanticipated finding.
Howard, you're going to give me a seizure.
Pardon?
You're going to give me a seizure.
It's jumping again?
Yeah,
you're going to have to
full
just
screen
go to full screen.
until this bug is fixed.
Okay. So this is a patient that on a follow-up exam, this is an unanticipated finding. It's a follow-up in a patient oncology. I think it was a gynecologic malignancy. So the opacities that I'm showing you here were unexpected. And there's one in the lingular division. There's one here, somewhat rounded, but this one certainly is quite large, and it's quite irregularly shaped. So I'm going to bring up the CT, goes along with that. And I'm going to show you some new findings, and then I'll show you one interesting finding. So again, this is not a CTPA exam, but we have nice opacification of the pulmonary arteries. So this, I will show you in a moment, is new. And then these are thick sections. There's something there, but here we go for right there. So there is a vessel, clearly abnormal, and it does not opacify. And you can sort of trace that down. It now becomes gray, and we trace it down very nicely to the pulmonary infarct. So we have pulmonary infarcts. The time between the two examinations was between June 13 and August 17. So those infarcts developed between the two examinations. And I'm just going to show you, out of interest, a follow-up exam showing you that small vessel that I showed you, sorry, go big, basically stays occluded. It never recanalized it. There's never fibrinolysis. So watch from this point. It disappears right there. And right now it's a very tiny thing, but this is a vessel that never recanalized, and it's now just, I suppose one could talk about fibrotic or thrombofibrotic occlusion of a vessel, even though it's not thrombus. But just a nice description and demonstration of pulmonary embolism, what it could look like in 2 months in terms of its evolution. And again, a reminder that not all vessels recanalize. This one is just shrunk down to nothing and is undoubtedly going to remain there forever. These infarcts have diminished just slightly in size, but perhaps they'll stay this way forever now, perhaps. So just a nice demonstration of findings in pulmonary embolism. All right, Jeff, those are my cases.
All right, thank you, Howard. All right, Travis, David, or Seth?
Nothing for me this week.
Okay.
I can go if you want.
Sure.
Oh no, get off the screen. Okay, good. There we go. Nothing that this is actually, I like this case. I'm sorry, I like this case. It's just something I don't see that often. Actually, it's just, I just don't think we see it. Oh, the tops got cut off. I'll have to resend it. Anyways, this is a patient who came into the hospital short of breath. She was convinced she had a exposure to Easy Off in the oven. She was convinced that she had been using Easy Off and was dramatically short of breath because of that. And you see we have a fair amount of ground glass opacity in the lower lobes, some very nice geographic areas of sparing. And then as we get to the upper lobes, we see a kind of some ground glass, but really nice, ill-defined central lobular nodules. And if you just see the generalized pattern of ground glass in the upper lobes, or central lobular nodules in the upper lobes and ground glass in the lower lobes of the mosaic attenuation. I always tell my residents that you should think of hypersensitivity pneumonitis, but this amount of ground glass is a little pronounced even for what I kind of term the inflammatory phase of this process. And it turns out that it wasn't the easy off, that 3 days before this patient came into the hospital, her sister or brother gave her 3 birds to watch while the patient, the sister family member, went out of town. And so they did a bronch biopsy. She's got non-necrotizing granulomas. She actually underwent an open lung biopsy because what happened was they showed this case to me, and I said, it's pretty convincing for a really kind of an acute lung injury due to hypersensitivity pneumonitis, which we really don't, again, the truly acute phase, which is this massive inhalational exposure over a short period of time, we really don't see that often. Anyways, they biopsied her and they treated her, and you can see that the findings are improved. We still have, she got rid of the birds. The underlying disease is definitely improved, but we still have this underlying pattern with lower lobe ground glass, some areas of lobular sparing. Somewhere in here, in one of these, I have expiratory imaging showing very nice air trapping. I don't know which one it is, or if it's even that nice, but well, believe it or not, this is a nice prone air, even though it's unintentional. Here's some air trapping on expiratory imaging. Anyways, so she underwent biopsy, confirmed the diagnosis of open lung biopsy after her bronch biopsy because she wasn't getting 100% better, even though we know that some patients won't get better even if we appropriately treat them and remove the inciting antigen. So they did an open lung biopsy to definitely confirm that it was HP, which it was. So, and we know that there are, subpopulation, they say a third, I don't know what the exact number is, where people, where you remove the inciting antigen, you treat them with steroids, and the lung disease does not entirely go away. But anyways, it's just nice because this is a case of truly what I refer to as acute hypersensitivity pneumonitis, where there is an acute lung injury. It's kind of a mixture of DAD and HP because of this massive inhalational exposure over a short period of time that then progressed to the more what we kind of consider what I call inflammatory, but other people call, or the old journals call, subacute. What do you guys, we were having debates about this. What do you guys term, I've moved away from the acute, subacute, and chronic. I think most people now call the fibrotic state, if there's fibrosis, fibrotic. What do you call the stage where there's what we consider the classic or the classic subacute? I call it inflammatory. Do you guys, what do you all call it?
I call it active, based on that Lacoste proposed classification. We have active for the fibrotic.
I didn't love that paper. Yeah, no, I know that classification.
Not the best term because you can have active disease with fibrosis.
Exactly, and
you can also have inflammatory with fibrosis. I kind of, especially when you have like a lymphocytosis on lavage. Honestly, the best term is probably fibrotic and non-fibrotic.
Yeah. I do use acute for truly the ones that come in with, it's so rare. This is only the second case I've personally seen where I do call acute when the case is where it's, a massive inhalation over a short period of time, and it's that mixture of DAD and HP.
And I wonder, it would be weird to develop HP that quickly. You said she had, how long did you say she had?
No, that's the people who have the acute, this is the second one I've shown. The one I was looking for in another article was someone who, what I emailed you guys was a guy who literally went up into his attic and started cleaning and developed it 6 hours later. So the truly acutes usually develop within 6 to 8 hours, and it's a massive antigen inhalation.
So they must already have, for a hypersensitivity reaction, that's the type 4 delayed hypersensitivity type. It takes some time. So they must have predisposed,
something. Yeah, because usually the acute's the type 3, and it supposedly suppresses more to a type 4 as it becomes more fibrotic. But nonetheless, you're right. It is a hypersensitivity reaction. But the people with the acute injury thing, it does present within 6 to 8 hours of exposure, and it's a massive exposure. It's like not like you're have mold in your wall. It's like you have a flock of birds in your house flying in your face.
It makes you wonder. I mean, because most people will test positive for serum pigeon droppings or whatever it is. That these people have an autoantibody, enough of it that when they get a massive exposure, it triggers the acute lung injury.
Yes. And that's why the acute is so rare, because you have to have both of those things. You have to have the exposure, the genetic predisposition with the presumed previous exposure, and you have to have that massive exposure on top of that.
Okay.
Subsequently. So, but yeah, it's that's why this is it's just uncommon, and why it developed so soon after her. Anyway, yeah. This is this is an okay case. Let me pull over. Over here, it got closed. So while I do that, I'll show this. It's a woman with multiple myxomas in the right atrium here. And if you hear the word of multiple myxomas, you're obviously going to think of Carne's. And this was, sure enough, a patient with, where is it? And I was just going to show because I have very nice, I have it under echoes of, here we go, showing. So she has these multiple myxomas, and I have MRI showing all the different, imaging of the myxomas, heavily T2 weighted images, less heavily weighted T2 images, T1 post images. We can see it enhancing. But here is nicely the TEE, which shows that this is like, she's had like 4 or 5 resections for myxoma. And the last one we have here, you can see one dangling in the LVOT. So we know most myxomas do not occur in the LVOT, and that most myxomas occur in the left atrium along the interatrial septum. Right atrial myxomas can be a little more variable. I've seen those all over the place. But A, if you have multiple myxomas, or B, especially ones in atypical locations like here in the LVOT, you should think of Carne's. And I always screw this up. Is it Carne's triad, or is it Carne's? I never.
Well, this is Carne's complex. Carne's triad. Yeah, Carne's triad is lung hamartomas, adrenal lesions, and GI stromal tumors.
I always screw that up. No matter whichever one it is, I always say the wrong one. So.
Yeah. Does she have skin lesions or other tumors?
I should check. I don't know. We just got her of, the history was Carne's, and assessed for new myxomas, and she had 2 new ones. So I did not check to see if she had dermatologic findings. What do they usually get?
They can get some sort of skin pigmentation and other tumors. I think they can get endocrine tumors, and I don't know. I have to look.
Yeah, I
don't remember.
Yeah, I can try to look to see. And this one is interesting because we've all seen this before, but I've not seen it. This is something I always, when I talk about it, always say it really should occur in the lower lobes, at least most of the. But although this is kind of in a aspiration location, so this is a young kid. I think he's 16 or 18. Here you can kind of make out, I have some follow-ups where you can see it more, some little bit of nodularity on the non-dependent portion of the trachea. And then we have this mass/mass-like consolidation in the right upper lobe, really kind of a mass with some surrounding nodules and some weird ground glass surrounding it. But most of the time when I see this, so this is going to be a squamous cell carcinoma in the setting of papillomatosis, and they took out the lesion that had all the positive viral markers for papillomas, the HPV and all that. So it was HPV positive. Most of the cases I've seen have clear, those little, sometimes solid, sometimes Cheerio stuff in the lower lobes, because that's where I assume most of the particles kind of go when you aspirate them, or just where most airflow is. But this one was in still a dependent portion of the right upper lobe, but not the most common location where I've seen the malignancy in these patients. I don't know. Again, I've only seen about 5 or 6 cases, but most of the time they're usually those little, in addition to the classic findings, the more cystic stuff in the lower lobes. The other interesting thing is that they, after treating him and putting him on chemo and stuff and weakening his immune system, this went away, fortunately, that his papillomas in his trachea got a lot bigger, which I have also seen, which makes sense as well. So just a case of tracheobronchial papillomatosis with parenchymal extension, although it's kind of obvious, I don't see it, the parenchymal extension, but the squamous cell cancer to prove that. And it could have been just a primary airway involvement of a squame versus a truly parenchymal lesion that grew. I don't know, but I don't know if anyone has any thoughts about how many they've seen in the upper lobes versus the lower lobes, but.
Yeah, no, I mean, I showed a case not too long ago that had a lot more parenchymal involvement, and the cancer was in the lower lobe. But
yeah, and that's every single one I've seen was in the lower lobes in terms of cancer. So, anyways,
it's still pretty dependent, and they can
yes,
hop around and whatnot.
Exactly. All right, well, those are my cases.
Thanks, Seth. All right, Travis.
Yeah, I'm ready.
All righty.
See. All right, do you see my screen?
Yep.
Okay, we're going to start with this case. This is pretty interesting, and I have path now. So this is a man who's 72, as you can see, and this is back in February. He went to an outside place and had worsening dyspnea over the course of months. Of course, in the acute setting, maybe you'd think pulmonary edema. He looks like he's got effusions. Heart's not that big, but tons and tons of what look like curly lines here, septal thickening. And he was treated for pneumonia, edema, something, I don't know. He came back, his symptoms improved a little, never really fully went away. And he comes back 2 months later, and you'll see on his CT that we have just striking septal thickening, and it's smooth in most places. There's a lot of peribronchial cuffing too. So it looks like it's some sort of perilymphatic or lymphatic process. And what's interesting is in the lower lobes, you get maybe a little bit of nodularity here, and you have this more discrete consolidation at the left lung base. So this is all done at the outside hospital. You can see he has small effusions and this thickening of the extrapleural fat that I think suggests that this has been going on for a while, and it fits with his symptoms. And so at the outside hospital, he got a bronch, and they somehow isolated Staph aureus from the bronch. There was no transbronchial biopsy done at the time. Gave him antibiotics. He got a little bit better, but not not back to baseline. He could only walk about 1 block at this point. But it wasn't until a few months ago that he got referred here, but we don't have any real other imaging. You can see on his follow-up radiograph that it's basically unchanged. So when he was referred here, kind of went through a whole differential, and I was wondering, he didn't have a history of a known cancer, wondering if he could have a lung cancer down here with diffuse lymphangitic spread, if this could be some weird amyloid deposition, some sort of other weird infiltrative process. I guess alveolar protenosis, maybe, but sorry, David, what were you going to say?
I love amyloid. I was waiting for amyloid.
Yeah.
Could be one of these congenital lymphatic lymphangiomatosis kind of things where you get.
Yeah, exactly. And that kind of went through our minds too, except I guess with his age would argue against that. And
how old is he?
He's 72.
Oh, well, never mind.
And same thing with like Niemann-Pick or one of these other deposition.
Didn't get his age.
Yeah.
How about Wertheim-Chester?
Yeah.
Right. And something else, his kidneys were fine, but or I guess we didn't get them, but his bones, we didn't see anything, or any other organs, and his heart looks okay. But on a transbronchial biopsy, I will show you what the path
Lymphoma.
showed. Yeah, exactly. And I'm curious, now tell me, since this is in preview, if this jumps or not, guys, when you see this. But yeah, so plasma cells, lymphocytes, histiocytes, and then they did a bunch of stains, and they thought this was a malt lymphoma with some sort of plasmacytic differentiation. So they thought he still hasn't undergone a bone marrow biopsy or anything to look for myeloma elsewhere, but this they think is probably a B-cell lymphoma. And of course, other things we talked about were here, but they, haven't really.
Interesting. I was thinking amyloid once. Yeah, that's after the.
Well, and that raises the question: if these are all plasma cells, is there amyloid deposition too? Which my question, I don't know if they did any sort of, if they did a stain for any sort of amyloid deposition. But certainly, if they're plasma cells, they could be secreting proteins. So
Well, they had kappa, a lot of kappa chains there in that report.
So pretty interesting, though.
Pleura is tremendously involved. That's really
I know. Yeah, and wonder how much of this, if they did a pleural biopsy, if you'd see plasmacytes in there as well. So
yeah, I've seen one case of chronic lymphocytic leukemia sort of look like this too, where you just plug the lymphatics full of leukemic cells, and I guess it's in that. I mean, this is sort of a lymphatic distribution. I mean, but yeah, wow, that's impressive.
And so there's no Congo red stains and stuff. I missed that.
No, I need to talk to our pathologist and see if they stained them or not, because we definitely brought up amyloid, and I thought that they would have done that, but I don't see it here. So, but that's really interesting. So I had not seen lymphoma present like that before, specifically like that. Okay, this is a patient who came into the VA, and this was done at an outside VA, and I'll get to the history in a moment. You'll probably be able to guess what the history is. And this is, of course, is a PE study. No PE. He's got effusions at this time, and maybe trace septal thickening. Not really a lot in terms of edema. You can notice that his right ventricle is a little dilated, and this was not noticed at the outside hospital. And I'll direct your attention to the lower portion of the interventricular septum, where you can certainly see that there's an abnormality here. And so it was, I always tell my residents, it's not, the question is never really PE. The question is, why are they short of breath? Why do they have chest pain? And this guy had an infarct, not surprisingly, 3 or 4 weeks before. And of course, you can see here that he now has an acquired ventricular septal defect, which accounts for why he's got all this over circulation. I think it's a good example because he came in to us then at the VA, and they did a gated CT just as planning to see if they can close this percutaneously. And this is a couple days later. It's a little noisy, but they haven't really intervened upon this yet. But I think the neck of this thing is only about 1 centimeter or so in size. But I think he still has the effusions. They've tuned him up a little. His RV is certainly still borderline enlarged. It kind of looks like shunt vascularity from this. But I don't know. We see maybe 1 or 2 of these here, and I know other people show them as well. But it's a good example of just of an acquired ventricular septal defect. Unfortunately, I don't have any pre-imaging to see what it looked like, when he presented with his MI a month ago.
Travis, do you think there's hypoattenuation of that septum, or is it just artifact?
I think it's right in here. I think it probably is. Probably where his infarct was.
Yeah, that's necrotic. Definitely necrotic.
Yeah.
We've had a couple of these cases recently, and man, it is a pain in the butt to measure that defect. Because not only but it changes. It's between systole and diastole. There's a dramatic change, believe it or not. Not dramatic, but a few millimeters in each direction. But their amplatses or their plugs are variable sizes, and
and you're putting it into, that was going to be my next question.
Necrotic tissue. They got
necrotic tissue.
Absolutely. No, we had oh, sorry, I interrupted. Sorry.
No, go ahead.
No, we had a woman, I think I showed, where they basically were like, yeah, we can't fix it, and the surgeons were like, it's too much necrotic tissue. There's nothing to fix. We can't even put a patch in. And they just sent her to hospice, and she was like sitting in the hospital and was like kind of fine. She's like, just couldn't fix it.
Yeah, because the other thing too, and I had one a couple years ago where it was right in the same place, inferior wall that ruptured, but it ruptured into the right ventricle, but also out into the pericardium, because the patient had hemopericardium and tamponade too. And there's not a lot of, I don't know how the heck you plug this thing, because you're right at the base.
Yeah.
It's not like it's right in the middle of the interventricular septum. Is it, by the way, is it jumping when I do the 3D view here or not?
No.
Not jumping.
There's a little, what's jumping, Travis, is your toolbar at the top.
Okay.
Well, the window's jumping, but just by a few millimeters, so it's not that
big. Bothersome.
Okay. So, but yeah, just So okay, so you struggle with measuring these two,
Oh
and
yeah,
also
and
what
we
to do.
do retrospective gating on it, and we measure at end systole and diastole, and we had one case where we measured it, and their device was it was a millimeter off or something, and they were very upset because they went in there to plug it, and their device is 22 millimeters, and we read it as 21 millimeters, and it was 23 millimeters, whatever. Who knows?
Okay, so
but yeah, it could be hard.
But yeah, so especially with unexplained edema in a patient recent MI, and I think most of our interventricular septal ruptures always seem to be inferior like that. So,
Very interesting.
all right, this is a nice one just because the radiograph. This is a patient who had a witness syncopal event, was unresponsive, required resuscitation, and you can see when they come in that they're intubated. And of course, if I told you this was trauma, you'd believe it because you can see there's deviation of the trachea to the right, and there's loss of all of your left side of mediastinal contours. So it certainly looks like it could be an acute traumatic aortic injury, except there's no history of trauma other than him just having a ground level fall. But you'll see here on the subsequent CT that was done, he's still intubated. And, kind of along the theme with Howard's case, but different case in this instance here, we see the large mediastinal hematoma, and even on the non-con, you can see the intimal flap being displaced. So he had both hemopericardium, as you see here, and mediastinal hematoma from a ruptured, no surprise, type A dissection. And I'll just show you the post-contrast as well. And you can see that there's a little bit of filling. I think the defect is probably right here in the lateral wall or anterolateral wall of the ascending aorta. But I think we probably have a little bit of shared sheath hematoma as well. But just a type A, forgot to maximize it there. So type A with rupture, there's another tear here. And I don't know, I'm always curious where these actually rupture, outside the adventitia into the mediastinum. I don't really see anything here, but he was able to go to surgery. They did do an ascending aortic repair, but he never got off the ventilator and unfortunately passed away. But I think it's a really good, good example of mediastinal hematoma and true widening of the mediastinum, not just a large patient. Because again, you lose all of your left-sided mediastinal structures and all the interfaces, and then the displacement of the trachea.
Yeah, very much so.
Yes.
And then I'll show this. So Seth, you're on here too, and we've got a lot of people I think maybe that can help answer this. So this is a 66-year-old woman. This is an interesting case because a patient has interstitial lung disease, and she was referred to us. And so she has like anterior upper lobe subpleural things, and you might say it's honeycombing. Some of them are a little bit larger and irregular air spaces. And then she has similar findings isolated to the posterior aspects of the lower lobes. And again, when we see these bigger air spaces, we start thinking more about smoking related fibrosis and the airspace enlargement with fibrosis rather than just discrete honeycombing. And moreover, she doesn't really have a lot of traction or reticulation. Unfortunately, this is the only CT I have. It's from an outside hospital, which it's thicker slices. But what's interesting, she had a significant secondhand smoking exposure. She wasn't a smoker herself, and she didn't have a connective tissue disease. And so they actually sent her to surgical lung biopsy. And I bring up all of those because this came back as airspace enlargement with fibrosis, so irregular emphysema. So I'm just curious if you guys have seen this kind of pattern in predominantly non-smokers, because it's not a UIP pattern, which would be part of that differential, and she still has zero autoimmune issues.
No, I mean, it's good. It's good to get path on it. It's good to see path on this case. We see this a lot, and we don't know what to call it, and our clinicians are like, "You're telling me that's not honeycombing," and you have to say, "No, it's not," and they look at you aghast when
because these are just bigger irregular spaces. And
the airways are there's no bronchiectasis associated with it.
Right. That's the other thing too, and
maybe minimal. I mean, because there's mild fibrosis, not like you see.
But some of these you can still see the airways going out, and they're not really that dilated. So it's just okay. But it was really interesting. But that's why she went to PATH, because there wasn't a lot of other fibrosis. I mean, everything else is pretty pristine. So it's just kind of weird. But
Yeah.
Jeff, were you going to say something?
Oh, I was going to say, it's just odd in a non-smoker. I don't know how to explain it, but
Yeah.
some inhalational injury did the same damage.
Yeah. I mean, yeah, they just said a very significant secondhand smoking exposure. So I don't know, but yeah, I think the point is too that not every cystic space is honeycombing, and I'm glad you guys agree too that these bigger, just bizarre spaces aren't. And of course, in this case, it makes a big difference because she doesn't have UIP or IPF, at least based on this alone. So,
Travis, do you think she could just be a really bad aspirator? I mean, there's some upstream,
yeah,
there's some mild bronchiectasis on top of it, and I wonder if it just does some sort of similar to the elastase. It does some damage that causes.
Right. This is just her body's response to chronic aspiration. I don't know. Yeah. He didn't find anything else to indicate.
It's funny because there's some people who say, IPF is secondary to chronic microaspiration. So
yeah. Well, and it has the right distribution, right? Like I know, like Galvin always talks about, there and there. It's perfect distribution. So I think Jeff, I think that's a very good thought too. I don't know. That's another question. Yeah, if that could be a cause of this irregular emphysema, airspace enlargement with fibrosis. So I'll look it up and see why you're presenting.
Travis, why are you the aspiration argument for the anterior stuff in the upper lobes? That's kind of out of the aspiration zone, isn't it?
I think if people are prone.
Yeah, rotate the sagittal to prone, and you can see that becomes pretty dependent.
Yeah.
So I don't know any adults who sleep prone.
Many do.
We had a case of, and I have it in my teaching files to show it, of someone with pronounced anterior fibrosis, and he slept. They asked him, and he slept prone.
Yeah.
And I should show that case because it was really weird, bizarre pattern, and it turns out he slept on his belly.
And last year, or within last year, when Jonathan wrote his paper on trying to differentiate connective tissue disease UIP pattern from IPF, and he talked about like the anterior upper lobe sign, like which I think, at least in the past, anecdotally referred to as the four corner sign. But I don't know. We see that in all of these different diseases, though.
Yeah.
So,
I don't buy this particular distribution here for aspiration. Most adults don't sleep prone because it hurts their back. She's 67 years old, and it's so localized way out against the periphery like this. Usually aspiration gets the central airways on the way to the periphery, and they don't seem to be very involved in her. This seems to be just sort of magically way out there at the periphery without tracking out there from centrally. So, aspiration's fine, I think, for the lower lobe stuff, but I think this case is not very convincing to me, at least, that the anterior component is the same process. So localized. The central part is so pristine.
yeah. Well, I guess I'm on the fence. I know that other people do make the argument that this is a common site of aspiration. I don't know.
But I don't think aspiration should give you emphysema. I mean, I understand like anything that could potentially obstruct a small airway can give you distal emphysema, but I don't know if aspiration itself pathologically ever.
Suppose you're aspirating, let's say, bile acids. Could that sort of digest some of the tissue that leads to the airspace expansion?
I don't know. I don't know.
Yeah, it may be her reparative mechanism. I don't know.
It's an interesting case.
Okay, well, I'm going to stop there, Jeff.
All righty. Let's see what I got here. All right, let me know if my screen jumps. I'm going to try to avoid it. This was a case I've been waiting on trying to get a diagnosis. This is how old is this patient? 67-year-old female who presented with sort of some inflammatory markers elevated and some chest pain. And you can see the CT shows two things in the aorta. You've got dilated aorta, you have a little atherosclerotic plaque, most of it's not calcified, but you also have this circumferential wall thickening that's quite pronounced. And it goes all the way down. And I would argue that, a lot of this is plaque, but even in the non-plaque areas, it's too smooth to just be circumferential atherosclerosis. And you can see this wall thickening all the way down, just above the bifurcation. So, some sort of aortitis. And in a 67-year-old female, we would be thinking of giant cell, which this turns out is not. And I don't know what's going on in the omentum right here, but and so her SED rate was elevated, CRP I believe was elevated, but no specific other markers, and there was no other site of disease. And so ultimately, after I filed this case for a while, she was just given a diagnosis of isolated aortitis, which can occur. There's a differential including syphilis, rheumatoid arthritis, things I mentioned already, and a few other things. But I don't know, you guys, Seth, I know you've seen a lot of this stuff, but have you guys ever seen a sort of just a nondescript aortitis that doesn't go with another syndrome or disease?
Well, I don't know what other people think, but I think we have a lot of times we see an aortitis or vasculitis, and we just label it Takayasu's or giant cell without path to show that there's giant cells. Or anyways, how often do these actually go to biopsy? It's so uncommon,
right?
But the answer is yeah. A lot of times I just call them an aortitis or a vasculitis. I try not to give it an eponym.
Yeah.
Person. But so there was no coronary involvement. There's no, like, the arch vessels weren't involved.
There's a little bit at the origins, but not really. I mean, you look at it, it looks pretty good. So
I'm sure they did like neck exams, and that was all normal. That's interesting.
They did a full workup, and this was the only site of disease. And you look at coronary, look really good too.
That I have not seen. So with this much disease in the aorta, I've seen it with, all the neck vessels and leg vessels, and not just. So
yeah,
I don't know.
And so I found some papers on it, and they just referred to it sort of as an isolated or aortitis. So, it probably is. Maybe it just hasn't declared itself systemically. Who knows?
No.
Jeff, there wasn't anything around the kidneys, a la Erdheim-Chester again.
No, and this is not soft tissue around the aorta. She kind of has lobulated kidneys, probably old microvascular disease. I mean, if you look at her renal arteries, they're not involved. So none of the medium vessels are involved. It's really only.
How old is she?
67. So she's a perfect age for giant cell.
Yeah, she's good age for it. Yeah,
definitely. And maybe it's just on the spectrum and just only involved the aorta for whatever reason.
So you said it was not giant cell. That was based on what?
The fact that there was no involvement anywhere else. They didn't biopsy her aorta, but at least the rheumatology evaluation didn't feel she had other symptoms. She really didn't have the PMR type symptoms that you see in a fair number of them. But I mean, could it be giant cell that's only involving the aorta? I presume, but no one's going to go biopsy this. And she responded pretty well to some steroids. I believe that's what they treated her with. But
and no involvement of the pancreas or anything else to suggest IgG4 disease related?
No, her pancreas actually looks really healthy, and it was very isolated. No other issues. I mean, that's why it's a conundrum. But it would be very easy, especially for someone less experienced, to just chalk this all up to atherosclerosis, because you clearly do have this plaque. Interesting, she doesn't have a lot of calcified plaque, so I don't know how much of this is secondary, but there's some of this must be some atherosclerotic plaque, but most of it I think is all aortitis. So she may get follow-up imaging. I don't know. All right, this is kind of a cool case. It's not a diagnostic dilemma. So this was a 15-year-old who presented with about 3 days of chest pain and has this nice mass in the prevascular mediastinum. So, an adult, we would think thymic lesion, although it's really big. But in a kid, thymic neoplasms are quite uncommon to rare. So then you start thinking about a germ cell tumor and then T lymphoblastic lymphoma. Given that it's unilateral, I would favor a germ cell tumor. And here is the CT scan that shows a nice heterogeneous mass. There's fat in it. There's a liquidish component. There's some weird enhancing soft tissue, quite large, more fat, and maybe some calcium in here too, and definitely some calcium in there. So good luck for a germ cell tumor. What's kind of cool about this case, and this is something I didn't know, they biopsied it. I'm not sure why, because typically you take them out. In a male, it's going to be malignant, and but they treat them usually first and then remove them. But anyway, I'm sure there's sound reason to it. But anyway, they biopsied it, and it showed a mixed pattern of, let's see, here we go. Yeah, so it showed he had elevated AFP, LDH was high, so there was maybe some tumor lysis kind of thing. So he had a little bump, little problem with his kidneys, but not too bad. And this was interesting. So his INR was elevated, isolated, and the biopsy showed a mixed histology. So they saw some that should be yolk sac, not yolk spa tumor, and a teratoma. So it turns out these mixed tumors in children, boys in particular, or males, are associated with Klinefelter syndrome, which I was unaware of at the time. And they sent off some genetic testing, which confirmed indeed that he did have Klinefelter syndrome. So it was not diagnosed by the age of 15. And apparently these tumors can inhibit some of the clotting factors, because they gave him vitamin K and his INR wouldn't come back down. So the pediatric oncologist had a wonderful note that explained a lot of this. So I actually learned a lot just digging through this case quite a bit. But it's a great example of sort of a teenager with a germ cell tumor. And I always teach my residents that if it's a male patient, it's almost certainly going to have some malignant components, even if it looks mature, indeed as in this case. And if it's a female, it's almost certainly benign. And typically in a female, you can just resect it and not biopsy it.
Jeff, I showed a case a couple months ago where it looked like part of it was benign looking teratoma, and then the rest had a more malignant look to it and malignant pathology. I didn't realize that patient had Klinefelters too. I didn't know there was an association.
Yeah, apparently is with these mixed germ cell tumors. There is, and that's the XXY. Yeah.
Yeah. So, I do. So we have a lot of these at the ARP, and not these mixed ones with the malignant, but we do see a fair amount of benign germ cell tumors in men. The papers really say there's no gender predilection for benign germ cell tumors between the genders. Malignant is almost all men. There's almost no malignant in women. It's case reportable.
Right.
Those are teratocarcinomas. And we've seen a couple of these here where it's very interesting, where they've actually metastasized, the tumors metastasize, and then they treat them and they resect. And I think I showed a case where they resect the primary lesion and the mets, because they do that for some of these tumors.
Right.
And the resection only shows teratoma because they've killed the malignant yolk sac tumor. And what's left histologically is benign teratoma. So they sometimes read these as like, metastatic benign teratomas, whereas in fact, it's not. It's they've killed the germ cell tumor, the malignant portion.
Right. I think Indiana University is where that whole treatment regimen started, and I think they have some of the most experience with this. But that's what they would do, is exactly, and that's why with this patient they're going to do neoadjuvant therapy. And there's a new drug. It was some unpronounceable drug that presumably takes out all the immature and yolk sac, embryonic tissue. And then they go in and resect the teratoma. Yeah,
exactly.
And it's often curative. And I've seen patients with lung mets that mature, and they take them out too.
Yeah.
Yeah. Cool. Well, we don't see too many of these because they're pretty rare. But I thought
no, I've only seen two since, but here only. I never saw them in Maryland. They have
Okay. Well, here's another interesting tumor case that just kind of one of these weird ones. So this is, I forgot how old, a 59-year-old man who presented with pleural effusion, shortness of breath. So chest CT here showed these pleural effusions, and the one on the left is quite large, and the one on the right's medium one layering, but it would make you kind of wonder about the one on the left in particular. And what I don't like about it is this mediastinal pleural stuff. It's kind of nodular, and then there's ugly subaortic lymph node or periaortic lymph node sitting right here. So clearly this looks like a malignant effusion. And then there's a couple of other interesting findings. Look on the right. So there's these subpleural nodules in the right lung, and you can see they're sort of little hypervascular component to maybe a couple of them, some of the bigger ones, but they all have these kind of very shaggy borders to them. even in the non-dependent lung. So clearly, I don't think this is just atelectatic lung. I would wonder if there's pleural involvement of this side. Look at these nodules along the fissures as well. So I think these are bilateral pleural metastases, malignant effusions. And so they did a pleural biopsy, and they got, interestingly, angiosarcoma. And so they did a PET scan, and I'll show you the PET scan. So you can see on the PET, this was actually pre-effusion, or the effusions had been drained at that point, remember. But coming down, you see there's some bone involvement. And then what's really cool is, and I'll make it bigger, is in the pelvic arteries. So we're at the bladder, but I went too far. Right there in the left common iliac artery is this area of FDG uptake. And we go back to the CT scan and scroll way down. You can see that there's this irregular, ugly, soft tissue. It looks almost like plaque, except it's very ratty looking. It fills most of the lumen. That looks more mass-like, and there's no atherosclerosis really to speak of in that area. So I think this is all this frothy looking stuff is all tumor. So this is a iliac artery angiosarcoma that has metastasized to the chest, and I think it's primarily pleural and then some lymph node involvement as well. But just a weird one. Someone showed that ugly aortic case a few years ago, or several years ago.
Yeah, I had two of those I showed. Yeah, that were.
So this
Can
is.
you show it again? Sorry, I zoned out. I was looking for this yolk sac tumor case. Oh, so that's, oh wow, yeah.
So this is a mini version of your ugly aortic one.
Absolutely.
Yeah, and then there's bone involvement too, if I remember the right button. Yeah, you can see there's involvement of the bones as well, but you see that much better on the PET. I don't think you see it as well on the CT.
That's bad, but that's a cool case.
Yeah. All right, and then quickly, this is one we've talked about, but this is an interesting case. This is a 28-year-old male. He's a smoker and developed over the past few years some progressive dyspnea on exertion, and this is his radiograph at the time, and you can see he's had some old trauma. He's got this apical thickening. It's fairly symmetric, but I think what's striking is the upper lobe volume loss and sort of the distortion of the mediastinum. Almost looks like an old radiated Hodgkin lymphoma. It's a little cleaner than that, but clearly there's some volume loss up there. And then he had a CT scan. I've got two dates. I'll show the one at the time of this radiograph first, and we see this, he's got an azygous fissure. He's got this subpleural reticulation that's more than you'd expect to see in a 27-year-old, but striking volume loss in the upper lobes and even some thickening along the bronchovascular bundles, but very much a subpleural fibrosis, not nodular enough to call sarcoid, in my opinion. And he's got that volume loss. Now, he gets sort of breath, so here we see him about 18 months later, and you can see it's gotten quite worse. He's developing more fibrosis up there. And at this point, he's already had a surgical biopsy, and the biopsy was very typical of pleural pulmonary fibroelastosis. So, his only risk factor is smoking. I failed to mention he had Ewing sarcoma as a child, was treated with cyclophosphamide, and carries this quote asthma diagnosis. But it makes you wonder, either this is a delayed drug reaction. His Ewing sarcoma when he was about 3, and he's a construction worker, so he may have some dust exposure, but that's a long time period from an old drug to now getting fibrotic lung disease over 25 years or so. So I have a hard time chalking cyclophosphamide up to it, but I don't know. I've seen it in older patients, but I don't recall, and I've seen it in one younger patient, but I don't know how to explain this one or what's causing it.
Well, I think, if you think that it's a microvascular insult, just an exaggerated response to what you see with an apical fibrous cap, then maybe the chemo did predispose it to it. Because we've had patients, I think we had one patient in particular that had been treated with chemotherapy as a young patient and then developed it later.
Okay, maybe it injures the lung, just like we see with radiation recall, where they get a drug later on and they get pneumonitis in the radiation zone. So maybe it's like a 2-hit thing or something. I don't know. Maybe, who knows? But I think that's probably the best candidate, though, is the old chemotherapy. And I wonder if we're going to start recognizing this more and more. as we see.
And one should make sure that he doesn't have familial pulmonary fibrosis that in this fashion.
Right, exactly, which as far as I could tell, he did not. Okay, well, thanks everybody, and I will talk to you in a few weeks.
Jeff, are you away next week?
I'm away next week, and then the subsequent week is Thanksgiving, which we will not hold a webinar. But the week of RSNA, we're all back, so we will resume that week.
Okay.
But Travis or Howard will run it next week.
I'm away next week too.
Oh, I think Travis left, but Jeff, go to my screen real quick, and I'll show you this case I was talking about.
Okay.
If you don't for half a second.
Yeah, I would love to.
So this is that case I think I showed. Maybe I never sent it. I don't know. Sometimes I don't send my cases where he had this germ cell tumor, mixed teratoma, yolk sac tumor, some mixed tumor that was treated, and he had all these mets that were treated, and the malignant portion was killed, but the benign teratoma portion has remained. And the problem is that these are tumors, they're benign, and they keep growing. So they get big, and they wedge them out or take them out, but they're all benign teratomas. So it was it was like your case. I don't know. I should check to see if he has Klinefelters. That actually be really interesting.
Yeah.
I never, I didn't really look in his history, and he may. That would actually be kind of interesting, but showing that kind of metastatic and all that's left are these benign teratomas.
Yeah. And my patient didn't even know he had Klinefelters, and it was the oncologist who sent off the karyotype, and sure enough, it was positive.
Yeah, no, I should definitely check this one out, because I didn't even know that. That's actually pretty interesting.
Yeah.
All right,
guys. Well, thanks for a great webinar, and I'll talk to you in a couple weeks, or I guess.
Bye, everyone.
Bye.